One of the things that also really interests me in sickle cell disease is red blood cell transfusion therapy, and then an associated risk with transfusion therapy. And one of those risks is immunization, or the formation of antibodies against what we call non-ABO blood cell antigens to the donor product that they're getting. The motivation to coming up with the study, which just to summarize, is that we were looking at the impact of having a pre-transplant history of red blood cell alloimmunization on post-transplantation outcomes, was that in previous studies where they have looked at HLA alloimmunization, they saw that there was an increase in platelet transfusion, but also was associated with some increase in GVHD, as well as some instances graft failure. So we wanted to see if that same kind of weight carried on with those that were red cell alloimmunized. And there was a study that was in 2019 that had seen that significance in those that were red cell alloimmunized and non-alloimmunized, where they had a higher incidence of acute GVHD, but that really wasn't the primary focus of their paper. It was like on a post hoc analysis, and they did comment about that significant finding, but it was just an area that really needed further research, and then that's what kind of encouraged us to do it too. Yeah, so it was a retrospective cohort study. We are very fortunate that the STAR registry, which had been created to really have a repository of data of transplant outcomes in our patients with sickle cell disease. So we had that readily available to us, and we had that data was already collected about red cell alloimmunization. So we were able to use the data set, and the PIs, which are Dr. Stenger and Dr. Abraham, have been phenomenal and really, really excited about this project. And so, as I mentioned, it was a retrospective cohort study. So we had pediatric patients with sickle cell that we analyzed, and then we looked at whether they had a history of red cell alloimmunization, and then we categorized them on whether they were alloimmunized versus not, and then looked at transplant outcomes based on that. Our specific real focus was looking at post-transplant transfusion, so both for red cells and platelets, and then we also wanted to look at more of the transplant outcomes such as graft failure, high-grade acute GVHD, and chronic GVHD. So that was kind of like the design that we looked at. So we saw, it was a little surprising to us. We thought maybe we would see higher transfusion post-transplant. And I will kind of take a step back that we only analyzed the matched related donor transplants. And the reason why we chose that specifically is that we didn't want any confounding factors by looking at matched unrelated or haploidentical transplants, which we know have been associated with either higher graft failure or GVHD. But in our results, we found that really the high-grade acute GVHD was significant in the alloimmunized cohort compared to the non-alloimmunized cohort, which we thought was really interesting. And kind of different theories that we think that might be causing this is maybe these patients are more inflamed going into transplant compared to the non-alloimmunized cohort, or maybe they have some form of mechanism that's similar in terms of activating the antigen-presenting cells, and that's what's leading to acute GVHD. Next steps would be lovely to analyze this in bigger cohort that have undergone match-related donor transplants, but I really do think that the next step would be looking at the alternative donor transplant, so haploidentical and matched unrelated, to see if we're seeing the similar incidence of high-grade acute GVHD with those that are alloimmunized versus not. And I think that will be more of kind of a supporting of the findings that we have found in our study.